Hello, everyone, and welcome to IDFA's Immunodeficiency Insight webinar. Tonight's topic is Think PI, Living Well with Immunodeficiency. We're looking at challenges, support, and daily strategies. This is brought to you in recognition of World Primary Immunodeficiency Week, and we're on the final day of that week today. This webinar is bringing together an immunologist and an IDFA member for a meaningful discussion about what it's really like to live with your primary immunodeficiency. Before I start, I would like to begin today by acknowledging the traditional custodians of the land on which we meet and pay my respects to their elders past and present. I extend that respect to any Aboriginal or Torres Strait Islander people here today. First of all, I would just like to introduce the Immunodeficiency Foundation Australia. You are all members. We are a member-based organisation and a peak body for people living with primary and secondary immunodeficiency across Australia. We currently support more than 2,000 people with an immune deficiency, carers of those people, and we have members who are health professionals as well. Our vision is a future where immunodeficiency are diagnosed early and managed effectively, where individuals are supported by clinicians, community and government to allow optimal quality of life. The three pillars of IDFA are to provide education and awareness, care and support by building community amongst our members, and advocacy by driving change, particularly in relation to research and health policy. So the webinar tonight will go through a guided discussion. We'll start off with Professor Katrina Randall, who will give us a clinical overview of primary immunodeficiency, followed by a discussion with an IDFA member. Then we'll talk to you about the resources and support that we can offer you and also what events we have coming up at IDFA. So this is our speakers, Professor Katrina Randall, who's an allergy specialist and immunologist, and Rob, who's an IDFA member. Professor Katrina Randall is an immunologist at the Canberra Hospital. She's also a researcher at the John Curtin School of Medicine at the Australian National University. Her PhD focused on rare immunodeficiency, and her clinical work spans a broad range of immune conditions, including primary and secondary immunodeficiency, as well as autoimmune, autoinflammatory, and allergic disease. We're very grateful to have her join us here today to share her expertise and insights. Welcome and thank you for being here, Katrina. I'd also like to warmly welcome IDFA member Rob. Rob is a former IT professional and stepfather of 3 adult children. After experiencing a significant decline in health and following a diagnosis of anxiety and depression in 2019, he retired from work. Rob was later diagnosed with common variable immune deficiency, or CVID, along with several other complex conditions. Rob speaks openly about his mental and physical health journey, and today he'll share his experience of navigating diagnosis, managing daily fatigue, and finding ways to stay connected with family while maintaining a meaningful and fulfilling life. Thank you for joining us, Rob. Together, Katrina and Rob will now explore both the clinical and lived experience of primary immunodeficiency and what it means in practice to navigate life with these conditions. To kick us off, I will now hand over to you, Katrina.
Thanks, Carolyn, and thanks to IDFA for the opportunity to participate in the webinar today. So I was just going to start with a couple of slides, but first a disclaimer that obviously I'm not providing personal medical advice, and please see a specialist or GP to discuss any specific issues that might arise from what I'm talking about today, and the views expressed here are not the views of either of my employers, either the Canberra Health Service or the Australian National University. So I was going to start with just talking about a diagnosis of primary immunodeficiency. The webinar is mainly about living with the diagnosis after it's made, but I just wanted to talk about the fact that a diagnosis of primary immunodeficiency is a clinical one and relies on the expertise of the specialist who's making that diagnosis. And they will look at things such as what the total IgG quantitation is, and they'll also look at the other immunoglobulins. They will look at whether you can make a good response to a vaccine challenge. So many of you may have had before and after blood tests for vaccines, particularly the pneumococcal vaccines. We also look in the blood at a specific white cell, which is a B cell subset. So our white cells are subtyped into lots of different types, and one of those is the lymphocyte, which is central to the immune system and fighting infection, and those are divided into B cells and T cells. The memory B cell component can be identified in the blood test, and some of you might kind of think about this particular blood test. It's the annoying one that sometimes can't be collected after hours or on a Friday afternoon, because it's a test by flow cytometry. And so this is maybe the test that you're always asked to come back and do another time. And we also look not just at the pathology results, but we look at it in the context of the person and the type and severity of infections that a person has had to make that diagnosis. Because just having abnormal blood results doesn't mean that there is definitely an underlying disease. A normal reference range, by definition, excludes 5% of normal people statistically. And so just having abnormal blood results doesn't make a diagnosis, but it's those abnormal blood test results in the context of the correct clinical manifestations that leads to a diagnosis of primary immunodeficiency. And I also wanted to just say that you can make a diagnosis of primary immunodeficiency even if you don't fulfill those criteria, that the all-important life blood criteria for whether you require antibody replacement or not. And that might be because your primary immunodeficiency is not related to antibodies but other immune cells, or it may be that you have a B cell defect but it just isn't manifesting badly enough at this stage for antibody replacement to be part of your management. Next slide, please. So I really wanted to concentrate on ongoing management and I guess the relationship that we have with our patients. Often when people ask, why am I an immunologist? What appealed to me about the sort of patients that we see in immunology is that it's an ongoing, sometimes a relationship with a patient for their entirety of their life, from diagnosis and through all of their significant life events. So the most important thing when I see a patient with primary immunodeficiency and I'm making a diagnosis is to make sure that we've explained what the implications of this diagnosis are, and to provide the education about what the consequences will be in the long term for this diagnosis. And I find that because primary immunodeficiency is very rare or quite rare, we really need to empower the patients to be able to educate other healthcare providers that they see about some of the things that happen in their disease. And I know it can be frustrating as a patient to have to always explain what is wrong with you and why certain things, are going to be different about how you present health-wise, but it can be really valuable for patients to be empowered enough to be able to explain to doctors. So the example I often use is, if you've got low antibodies, then it's not helpful for blood tests that rely on antibody production, and a lot of pathology blood tests, particularly for infectious diseases, rely on the test finding the antibody to a particular infection, and that's how the infection is detected. But if you can't make antibodies, that's obviously not a very helpful thing. And so it's important that patients understand this. And I guess even more importantly, once you're having antibodies that have been produced in somebody else, another donor, then those blood tests again become completely useless because they don't reflect what infections you're fighting. They're reflecting the infections that were being fought by the donor of those antibodies at the time the donation was made. And sometimes it's important to just be able to step in and say, are they my antibodies you're testing, or perhaps the blood banks? And that can just make sure that there's not sort of unnecessary testing done. Some of the things we discuss are, what are the implications for lifestyle and work, and what sort of precautions might you have to think about to make sure that you're not exposing yourself to too much infectious risk. We talk about, if you're eligible, what the options are for antibody replacement, whether that be intravenous or subcutaneous, and where the best place might be for you to get that antibody replacement. Talk about the role of vaccination and how it's important to avoid live vaccines. Talk about family planning and what the possibilities are for how this condition might affect a future pregnancy, and what the implications might be for a baby born of a parent who has an immunodeficiency. And sometimes this is the opportunity to talk about doing genetic testing for the known genetic variants of primary immunodeficiency. But of course, talking about the risks and benefits there, in that we may not find a reason or a genetic underlying defect, and that can sometimes bring more uncertainty. And I guess one of the important things is to make sure that people know about travelling with primary immunodeficiency. Obviously, we want to be able to empower people to do all of the things that they want to do, and patients should be aware that they can take their subcutaneous immunoglobulin overseas as long as they get an export permit. But these are things that can't just be organised the week before you leave the country, so there has to be some planning. Obviously, it's important to have travel insurance that might cover you for serious infections. Try to find a travel insurance company that doesn't exclude infections because of your pre-existing condition. But just also think about which countries you might be visiting, the travel vaccines that other people would have, and whether you might be excluded from those because there's only live vaccines available. Next slide. So ongoing management of primary immunodeficiency does require regular visits with a specialist, and that's not just because of the Australian regulatory environment where we have to apply for the antibody replacement every 12 months. It is also to make sure that we can monitor for other side effects. We want to make sure that if you're on antibody replacement, that antibody replacement is at an adequate level, and that you've been able to avoid infections. And do we have to adjust anything to do with your antibody replacement or other things to try to avoid infections? The immune system is obviously critical for avoiding infection, but the immune system can also be important for monitoring or surveying the body for various cancer cells and removing them. And so overall, people with problems with their immune system statistically have a slightly higher risk of cancer than the general population. And that can be worrying for people to hear, but of course, not everybody with immunodeficiency gets cancer, and lots of people get cancer who don't have immunodeficiency. But it's just an awareness of making sure that you are doing all of the screening tests that everyone else does, and then probably in the situation with CVID, perhaps also making sure that you've had Helicobacter pylori, which is the bacteria in the stomach, tested for and removed to decrease your lifetime risk of gastric cancer. I guess the cancer that we worry about the most in antibody deficiencies is the development of lymphoma. And so I'm sure you've, been poked and prodded by your specialist at multiple visits where we are kind of checking to make sure that there's no enlarged lymph nodes anywhere. But again, a very low chance, but one that we don't want to overlook. We also know that there can be a decline in lung function, even if your lung infections are under control. And so you'll be asked by your specialist probably to have some routine lung function tests on a kind of semi-regular basis so that we can detect and manage any changes that we see there before you actually start to have symptoms. The regular visits are important so that we can have an ongoing discussion about family planning, because sometimes what you say to the specialist at the first appointment when you're 22 is not the same as what you say to your specialist when you see them at 34 and you've brought your wife to the appointment for the first time. And so this is an ongoing conversation about what we might have to kind of discuss in the before someone tries to conceive. Again, genetic testing, it may be that it's not as important when you're first diagnosed, but that it becomes more important later on, particularly if there's other people in the family who've now got a genetic diagnosis and you want to check if you carry the known family gene. Again, travel with primary immunodeficiency, it's very important that, again, this is an ongoing conversation so that people can take advantage of their opportunities, but also do so in a safe way. And last but not least, I think it's really important that there's great communication between the specialist and the GP who often acts as kind of an organizer of all of your different specialists, needs to be aware and be able to coordinate what's going on. So we need to make sure that you're not just seeing your specialist, but you're also seeing your GP, and that communication is great between the specialist and the GP. So I think that's the end of the kind of introduction to why we see people on an ongoing basis with PID, and I'm looking forward to hearing Rob's point of view about how the PID has kind of affected him and some of the issues that he's had and questions that he has about that.
Thank you, Katrina, for that very practical and insightful presentation. I'd now like to introduce and hand over to yourself, Rob.
Thanks very much. I'd firstly like to take the opportunity to thank IDFA and Carolyn and Hannah for the opportunity to talk about my journey and some questions for Professor Randall. So just in terms of how I've structured this, I've got some points and I'll make some commentary about those points. I'm not an expert on the journey. This talks about my journey. I recognize that everyone's journey will be very different or maybe very, very different, but I think there is some commonality. And then as under each point, I've got a rhetorical question for the audience. How did this manifest in your life kind of thing? Or what did this look like for you? I'll talk a little bit about how it manifested for me. And then I have a question for Professor Randall and Professor Randall. Most of these are opinion questions and observations, which is kind of, my interpretation of what we're after here today. All right, so just in terms of framing the way I've approached this, the theme of PI Week is We Can't Wait. I recognise that many people in the audience already have a diagnosis or are family members of people who have a diagnosis. So I thought rather than talking too much about we can't wait for diagnosis, but we can't wait for living well. So that's the linkage that I've created here. So I've provided some examples of what living well might look like for any of us, and some examples of what it looks like in my life. All right, so onto the first of the topics. So we can't wait. Reframing urgency beyond diagnosis. Even after diagnosis, new diagnostic challenges emerge. The PI diagnosis doesn't necessarily end the uncertainty. It just shifts us, or certainly in my case, shifted me into the next uncertainty. So PI was part of unpacking that. It came as quite a surprise. And of course, one of the things I recognized quite quickly was that as soon as I had a PI diagnosis, it kind of felt like everything, I was being referred to various specialists, and everything felt a little bit like it was, oh, that's because of your PI. Now, as I'll discuss in a sec, that was not quite the case. Um, and so because my PI created atypical symptomology, I would go along with a cold. And this was always the story. And I feel a bit guilty now, but throughout my life, whenever I got a cold a flu vaccination, um, I thought literally everyone was being soft. I'd never had any impact from it. I didn't realize that I was meant to have some sort of impact. So now I've realized when people complain about, how painful their flu vaccine is, that, they should feel good that they have a robust immune system, unlike me who just shrugs and like whatever. And one of the things we see often, which comes with some frustration, is some disconnected communication across medical teams. And as uh, Katrina mentioned before about first line treatment with GPs and doctors who may not understand PIs very well, and certainly don't understand your atypical symptomology. You turn up, say you've got a cold, or you're feeling unwell, they have a look, your throat's not red, your ears aren't inflamed, you're not coughing up lots and lots of green stuff, and they say, well, you seem okay, but we know we're not. So, in terms of my diagnostic journey, as a child, I was regularly sick. I had chest infections. I I would have been considered a sickly child. In previous generations, I would have been one of the children that, probably didn't quite make it past childhood. Um, I increasingly through my life, I was getting more and more and more fatigued, and I would just grind on through. And my CVID, ironically, was diagnosed while I was recovering from mental health issues. And my doctor gave me the advice to do things that make me feel good. So I had gone to the blood bank to donate plasma, and I received a letter from the blood bank saying that my immunoglobulin levels weren't correct and that I should consult my GP. So that was I think the stats are that most people take 7 years for a diagnosis from the time they start their journey, whereas mine was sort of a lifelong journey until this particular act. And then the diagnosis of PID was very, very fast. So thank you. ACT Health has been absolutely fantastic in helping me with that, and as Katrina. So the rhetorical question for the audience: how many of us were diagnosed quickly, and how many went through years of not quite having the questions to explain your symptomology? And then discussion question or opinion question for Professor Randall. From your experience, what are the most common ways people with primary immunodeficiencies are misunderstood or overlooked before or even after diagnosis? And how can clinicians stay better curious when something doesn't quite fit?
Yeah, no, that's a really good question. And I think it's just important to always keep an open mind when something doesn't fit. And instead of, I think sometimes when someone's kind of not behaving like the textbook, maybe the doctor can kind of get frustrated because if only they were just like, the textbook, it would be much easier. But I think we have to catch ourselves and in that frustration, and recognize that that's a problem we have and not the patient's fault that they can't, behave like the case study that we learned about in year 3. And so I think, yeah, it's about always questioning our own attitudes as well as what might be happening to the patient.
And this goes to the issue of self-advocacy, that we need to remind ourselves that we're not at fault here. There's something wrong, and diagnosis sometimes can be a bit slow. Sometimes they can come more quickly, but as we learn more, settling on the first point of contact and the diagnostic criteria for us as individuals. Next slide, please, Caroline. So stability is the next theme. So the So I found personally, and I understand this is a journey for many people, that very quickly we get to the point with treatment and recognition that we need to isolate, and we need to sanitize and stay away from people with colds and that sort of stuff. So very rapidly infection rates are reduced. I know personally that it would not be unusual for me to get 3 or 4 colds in a year. Sometimes those colds would end up looking a bit like a flu, and at one time I had pleurisy. I didn't realize pleurisy was a modern thing. I thought it was something that pirates had, back in the 16 or 1700s. I didn't realize it was just a different type of infection. And that from a test perspective, which is what Katrina was talking about before, the results might look quite stable. The numbers look good, but it doesn't mean we feel well. So one of the observations I had was that treatment stability, going through learning the lifestyle things to watch out for, as well as getting, I'm a SCIG patient, as well as getting SCIG, was that stabilization, and it was really the foundation for my life stability. But one of the things I recognized very quickly was that the way the medical system works, that we've got people who are diagnosing us with primary immunodeficiencies, and that's fantastic. But what we don't have is really much of a consideration of the broader life. So now we really kind of need to look after ourselves a lot better. And so looking at broader allied health support, I found that there was a lack in terms of diet and nutrition. People like Katrina and my GP have been absolutely fantastic, but their job isn't to be a dietitian or nutritionist. Exercise. And so again, I had to go on this journey. I'm very fortunate that I have some friends. I have a friend who's a dietitian. And I was already dealing with mental health, and I understood quite quickly that that there is a correlation between primary immunodeficiency and mental health. Some content talks about whether primary immunodeficiency is causal in terms of people getting depressed because their life has changed. I'm an example of where I had depression and anxiety without knowing I had primary immunodeficiency. So while medically it may have contributed, psychologically it didn't. So, knowing how to move forward with diet and nutrition, simple healthy meals that we can eat when our energy's low, as well as exercise, just simple walking. So what did this look like in my real life? My CVID diagnosis was able to be isolated, and then it laid the foundation for my GP and other specialists to diagnose other comorbidities for me. So as a consequence, I found that, so for example, I had 2 teeth that had persistent infections. So as you can see by my pirate smile, I had to have 2 teeth removed, which again, and I noticed that almost immediately that I got about half an hour of extra energy each day by having those removed. So some of these are very slow moving targets, and others you can see the benefits of quite quickly. So for me, the question I realized I was trying to answer was, is my health stable enough to start rebuilding my life? And I guess I circled that a long time before realizing that I needed to think about my whole life and, how I was interacting with all of that, not just my CBID treatment. So audience question, rhetorical question for the audience. What helped you move from stable to start living well? Um, and question for Professor Randall. When a patient is clinically stable but not feeling well, how do you personally think about that gap? And what have you learned about supporting the whole person, not just the immune system?
Yeah, I mean, I think, it can be, again, one of the things that we can be frustrated about as a doctor, because we know that we've seemingly plugged the gaps of the immune deficiency by, replacing the antibodies, and yet, unfortunately, people feel better, but not as great as they should. But I think it is important to just make sure that we do think about whole person things. So finding out a little bit about, what else they're doing, and try to provide those supports for other things. Unfortunately, the way the health system is set up, we don't often have access to dedicated allied health supports for PID, but we can certainly suggest to patients where to get those resources. And, one of the things I often say is, there's this patient support organisation, IDFA. They've got a great website. Why don't you see if you can start there with some ideas about, where to from here.
Mm, mm, wonderful. Next slide, please, Carolyn. So one of the things I realized, perhaps a bit more slowly than I should have, is that the currency I was dealing with is energy and capacity. So this was not about. So once I stopped focusing on my health and going to appointments, and I'm sure there's a story we all recognise. Once I stopped focusing on my day-to-day health appointments and all of those types of things, I realised that I was going to have to be responsible for managing that. Treatment was fantastic. All of the insights I had from medical practitioners and allied health were fantastic. But at the end of the day, I needed to take personal responsibility for my life and how I was managing that currency of energy and capability. So my daily life is less linked to time. I'm somewhat fortunate that I have retired now. That wasn't entirely an upside, but now I've kind of recognised that I probably got to a much better place than I otherwise could have. And my energy is a finite resource. So therefore, every decision I make, we every decision we make is a trade-off about, if we do something today, what does that mean tomorrow? Will I have the energy to do something? Because we're people, and we lived through the generation of, or many of us lived through the generation of the Codral lads and soldiering on. We even if we are feeling exhausted, even if we are feeling tired, we often just push on. There's an expectation that we work 9 to 5, and Australia has a culture of not being very sympathetic to people with invisible diseases or invisible illnesses. Also, the burden of explaining to our family, our friends, our workplace, our workmates, our bosses, that we have very, very limited energy. We often have cognitive capacity to do our jobs, but it may just not last as long as it does for some people. And occasionally with friends, family, workmates, we have to cancel plans because we just run out of energy. So there's always this sort of cognitive burden, for me at least, of constantly managing and explaining. And I'm very open about my health journey, about mental health, and as well as immunodeficiency. And I see that part of my responsibility is not to hide from this thing, but to advocate for not just myself, but for the entire community. Fortunately, I have a dog. and my dog likes to go for walks. So he pesters me if I on those days when I really don't feel like going for a walk. I also wear health trackers. I know not everybody wears health trackers, but I've chosen to, and I can see it's I'm no longer comparing my health and fitness to the general population. I'm really comparing it to what I was like last week, last month. In addition to some of this, by removing the primary immunodeficiency, I was also diagnosed with narcolepsy in 2021, which means that some of the treatment for that was literally managing with cups of coffee, some caffeine, as well as naps. So I was doing a little bit of contract work, and I was explaining to people that I have a medically diagnosed coffee and nap breaks. So, which was kind of nice to tell a doctor, but tell a boss, but I don't think they were very receptive. This means that most days I have a nap, 2 to 3 hours, which is again very fortunate that I'm not working. I was working for a while a few years ago, and I was very fortunate to be in a position where I was able to. I was as a contractor, I was only being paid for the hours I was working. So, audience question: what strategies help you manage your energy, not just your time? And a question for Professor Randall. Energy limitation is something patients often talk about, but is hard to measure clinically. How has hearing those lived experiences changed the way you think about care or treatment decisions?
Yeah, so obviously fatigue, and particularly post-exertional fatigue, is not something that we see only in our patients with primary immunodeficiency. It's also quite characteristic of the patients that we see with, connective tissue disease. And again, trying to give people strategies and reassure them that yes, fatigue is terrible, and no, medicine hasn't really come up with any great kind of treatments for fatigue yet. But just to reassure people that this is, not it's within the kind of expected symptomatology for their condition, and then to talk a little bit about some of the strategies that I've learned from other people that have helped them. So, I think particularly for fatigue, I've learnt much more from my patients than I ever learnt in medical school about how to manage it.
Mm. And do you think that's, you just mentioned medical school and not really learning much about it. Is this a thing you think most practitioners really pay attention to? Or what's your experience been with other practitioners? Do they just kind of shrug and say, that's a thing, it's
Again, yeah, I think it's doctors like to jump in and help. And because fatigue is one of those things where we don't have a magic pill, and we know essentially that we're not going to be able to fix it. I think some people find that difficult to deal with as doctors because, it's about sort of helping people. And I think so sometimes that can mean that people either minimize those things or skip through them when we're discussing, what can we do. Often management of fatigue is overlooked again because we don't have anything we can offer except support and suggestions for energy management.
Yep.
And so I think it's I think that's one of the reasons that doctors don't want to hear about fatigue, because again, I think it makes us feel like we're useless. We can't help you with that, and so we want to skip through to something that we might actually have a pill or a potion for. But I know that people do need the validation and the discussion about fatigue and how much it affects their lives. So.
Thank you. Next slide. Thanks, Carolyn. So one of the other things that I realized quite quickly was that there is a burden with treatment. So the heading I've put here is the hidden work of staying well. So for me, it's not just about sitting down and doing a treatment. It's literally how I'm thinking about my life, and do I need to take an antihistamine today? When am I going to be doing skig? If I'm going away for the weekend, do I need to bring my infusion forward? Um, and so this is invisible from the outside. People don't see this, whereas from the inside, it can often feel like a part-time job, particularly if you're unwell. And I've had the experience of going to the chemist when I'm unwell, and having to re-explain, and going back in a week's time because I still have the symptoms and having to re-explain, but this time sort of again re-explain while the chemist or pharmacist is looking at me with a critical eye about, why am I buying so much of this particular medicine, that kind of stuff. And as we all know, just the relentless scanning of our environments to threats to our health, and whether it's from children, visitors, friends, workmates, and just constantly asking those questions about, do I need to put on a mask? I carry a mask with me everywhere, and I have zero problems in just whipping it out of my pocket and putting it on when I'm in a cafe, in a shopping mall, anywhere. I largely avoid crowds these days, so I used to love going to large concerts, stadium concerts. I just don't do that anymore. As well as just asking those simple day-to-day interaction questions, how can I open that coffee shop door without touching it with my hands? If I'm going to an event with someone, should I take my own car rather than travel in a car with someone who's just returned from interstate? So and as we know, interstate planning requires an additional layer of energy and effort. International holidays are a whole thing. I know IDFA have got some information around that, and Katrina touched on that before. Public transport, so picking the times of day, and if you get the time of day wrong, it can feel a little bit like a science experiment. But these are the things, and sometimes we just choose not to do things. Um, so um, for me, what this meant in my life is that I've had to make choices about family events. We try and do dinners outside. Now I have three grandchildren. So about how I interact with them. Kids like to slobber anywhere, and so as I sort of have to constantly explain to my stepchildren, sort of what's good for the baby exposure is the opposite of what's good for me. It doesn't improve my immune system. So, it's and people can have a really hard time reconciling these things. Babies are just little, mushy germ carriers, and they're lovely things, but they're just not my favorite things. Um, so ultimately, this burden of staying well is often the cost to me is that I just need to sleep more. Sometimes I'll have a busy week and it will result in me sleeping for half a day, 16-hour days, that type of thing. So, a question for the audience: what part of treatment feels manageable and what feels overwhelming? Um, so, a question for Professor Randall. From your perspective, how do you balance the clinical benefits of treatment with the real world burden it places on patients? And how do you approach the conversation about sustainability?
Yeah, look, I mean, I guess I probably have a bit of a kind of doctor's view that you need this treatment to keep you well. And so, unfortunately, it will have to proceed. And yes, it does come with downsides, but that the sort of organization of how you're going to do your treatment, where you're going to do your treatment, keeping up with your appointments is just one of the things that has to happen to keep you well.
Yep, and I mentioned a couple of times, and I don't mean to feel like I'm preaching to anybody, but certainly I've taken that on as a personal challenge that it's my responsibility, and the doctor can't make me take the tablets, the doctor can't make me walk, the doctor can't make me eat spinach. Um, I'm a grown man; I can eat ice cream for breakfast if I want. My type 2 diabetes might argue with that, but yeah, we have to have some personal responsibility for that. The system is doing what it can, and people like you, Katrina, are doing amazing work, and I thank you again, as always. But yeah, we do need to take on some of that work for ourselves. Thank you. Next slide, Carolyn. So one of the things that I really struggled with through both mental health and also with PI and my energy levels decreasing and treatment and not being able to engage with the world as I used to, was that I started to lose a sense of identity. I started to lose the what I always felt were my strengths. I was always kind of the get it done guy. Um, I started to feel like I was no longer a robust person, not being able to engage with children, with grandchildren, with crowds. I started to feel quite fragile. Yeah, being the guy whenever we go to a coffee shop, say, "Oh, can we sit outside?" Watching friends shiver outside an Indian restaurant because the inside part was busy. I started to. I think it was quite easy for me to feel like I was just a burden. Fortunately, I do have good friends around me. I have lost some along the way who couldn't understand, didn't understand, but I felt that was a price worth paying. I have to be a personal advocate, and I have to be personally responsible. So for me, that shift in what my identity was. I spent 30 years in IT. I was at the end of my career, I was a delivery guy. I was working, 12-hour days. I was, getting things done. We were getting awards. We were getting a bunch of things that they were great. We were doing good work, and I was really proud of it. And then over a period of probably a year or so, each day was just getting more and more and more difficult to get up and get to work, and I was sleeping more and more. But I'm a bit stubborn, some might say, and I refused to rest. I refused to take breaks, and I was just not bouncing back, and that's where my life kind of fell apart a little bit. So it's taken me a while now. I was diagnosed in 2019, so it's taken me a while to redefine myself. And so what I've started doing is I've started to take on some projects. I've been working on some treatment frictions that I've recognised, and I will talk to IDFA about that fairly soon. In fact, I just today I lodged a patent application for a device that should remove friction for me and hopefully for many others who self-administer, as well as in a more formal medical setting. So rhetorical question for the audience: how has your definition of living changed? And question for Professor Randall: over your career, what have patients taught you about living well, and what it means and how that changed your definition of successful outcomes?
Yeah, look, I mean, I think we learn from all of our patients, but one of the things that I've been particularly proud of is taking women through their pregnancies with PID, and kind of really seeing the importance of being able to just help people achieve in their lives what they had planned to do before their diagnosis. And so that's, I guess, one of the things that's taught me that, yeah, people have their plans, and we really need to make sure that that they can get as much out of life as they would like.
Wonderful. I've just noticed the time. So, Carolyn, next slide, please. I've just noticed the time, and I think I need to speed up a little bit. So I do apologise to everyone for taking a little bit longer than I'd intended. So the next slide does touch on a number of things that I just spoke about in the last section, and that is some of the treatment frictions. And I think this was one of my challenges, was that I was getting tired from the illness and other illnesses, but also the navigation of the system. I know that there's an administrative burden. We have no choice. That I'm very, very grateful in Australia that we have treatment options and we get those mostly paid for. Um, and we all know the friction of engaging with new doctors, whatever, and having to explain our illnesses repeatedly, as well as the proof of burden, feeling like people don't believe us. And some of that can feel like a thing that we're not really enjoying. But I have had a couple of conversations with IDFA, and there's probably a few things where we're going to discuss that, we might be able to reduce some of the frictions in that space. Templated discussions for conversations with our GP, as well as some specific language. One of the challenges I've heard from doctors and specialists is that sometimes it can take a little while to unpack what people are telling them. So I thought, perhaps there was some opportunity there to provide some guidance in terms of what those conversations might look like using language that specialists can understand. I will skip over my anecdote there. And Katrina, if you're okay, I won't ask you this one, if that's okay. And so the audience question, what parts of the system help and what creates friction? And I'm sure IDFA, I'm volunteering Carolyn and Hannah here. I'm sure they would love to hear about some of those very specific frictions in terms of, whether there's anything they can do for the advocacy and some of the work I'd like to talk to IDFA about. Next slide, please, Carolyn. And so this is the final slide. For me, it was about adaptation and agency, building a life that worked for me. So the system can help me. The system has given me treatment. The system has given me guidance. But at the end of the day, I need to be responsible for my own health. So I need to self-advocate and I need to have personal agency. I need to feel like I'm making decisions. And so I've been very fortunate, and hopefully everyone else has, that GPs and all of the medical team that I've worked with have been extra patient with my daft questions. I like to understand things, as well as supplementing that with trying to find credible sources on the internet. So there's how to the immune system on a page kind of stuff, like how do you dumb it down for people like me? It's incredibly complex, and people like me, I just need to sort of understand the big ticks. So I'll finish this off with a it was a bit of a comment from a friend of mine. We were talking about this and doing meaningful things in life. And this friend said to me, there's a famous story. It talks about a gardener and a passerby. And the passerby says to the gardener, why do you keep tending this garden? It seems pointless. So we just need doing again. And the gardener smiled and says, yes, but I love gardening, and tending it is its own reward. When I care for it, I can spend time in it and it brings me joy. And that was quite meaningful for me. That's how I feel about my life now. My life is still my responsibility. The choices I make day to day, hour to hour, these are the things that will allow me to live the life I want to live. So, audience for the question, what is one change that has helped you live better? And a very quick question for Katrina, if we have a minute or two. Looking across patients you've cared for, what patterns have you seen in people who are able to build a life that works for them, and what others can learn from that?
Yeah, that's a pretty hard question. I think, your insight into your condition kind of is inspiring, and I don't think, some people have the insight into what they need to do, and some people you have to kind of guide a bit more about, some of the things they could consider in kind of improving their health. But yeah, I don't think there's actually an answer to your very excellent question.
No, I think this is part of the problem, right? That if it was an easy question and these were easy issues, we would all be doing it. So, life's a journey. These adaptations are journeys. So, just in closing, just a thought about the topic. So, bringing it back to the Primary Immunodeficiency Week. We can't wait. For me, has transitioned from we can't wait for a diagnosis to we can't wait to recognize what's not working and, of course, what is working. We can't adapt. We can't wait to adapt when things change. Katrina mentioned about keeping an eye on various things, and so we can pick them up as early as possible, early as practical, if there's some other treatment option we need to pursue. And in terms of living well, we can't wait to define living well for ourselves. And that's a personal challenge I've taken on. And I think it's going to be a personal challenge for everybody in these situations. And that's it from me. Thank you very much, Carolyn, and thank you very much to the audience. And thank you, Katrina.
Thank you, Katrina and Rob. And I think that really highlights the challenges in the complexities of not only diagnosing a primary immunodeficiency, but the challenges that come day to day with managing the many aspects of life that are impacted by a primary immunodeficiency. And I think that through the conversation with Rob and Katrina, it really highlighted the importance of communication between clinician and patient and the importance of partnership. And so I really want to thank both of you. That was an absolutely fantastic webinar, and I think so practical for our audience and for the members that we field questions from every day. So really thank you both so much for those presentations. So just to finalise the webinar, and this information will be available in a recorded format on our website. So Katrina mentioned the IDFA website, which we've done a lot of work on over the last couple of years. So there's a whole range of resources that are listed here and that you can download for free of charge on the website, whether it's wanting to understand PID and diagnosis, living with the PID, treatment. We have a range of self-advocacy tools. We have resources for clinicians and GPs, and we have support, community and education tools. So please feel free to investigate those resources via our website. I'd also like to just talk to you about our coffee clubs. So Coffee Club is a concept where generally we encourage our members to host a coffee club in their local community. IDFA assists with promoting the event and also picking up the tab for the coffees. So we have a couple of events coming up in the next month or so. The first one is, in Canberra on Sunday, the 3rd of May. And the next one is in Goodwood in South Australia on the 23rd of May. We also have an event section on our website where you can check those events. And if you would like to host a coffee club, please get in touch. This is just an overview of our webinars for the rest of 2026. We generally have webinars every second month. And as you can see, the next one will be around winter safety for immunodeficiency on Thursday, the 4th of June. If you have a particular topic you'd like us to address or you'd like to talk on, please feel free to get in touch because we're fairly agile at being able to put these webinars together. It's one of our key educational resources that we've been doing on a regular basis for our members. I'd also like to just recognise Grifols, who sponsor the Immunodeficiency Insight webinars for 2026. So in closing, I'd just like to again shout out to Katrina and Rob and a big thank you for all the preparation that you put into today and all the work that you both do, Katrina in the clinical space and Rob in the patient space. And we look forward to progressing some of those ideas that were discussed today. So thanks to our speakers, thanks to my colleague Hannah, who has put this very professional webinar together and spent a lot of time getting to know Katrina and Rob. And thank you to our audience, and have a lovely evening.